Good afternoon and welcome everyone, and thank you for joining us. My name is Christopher Ginder. I'm the Regional Director of Civilian for Public Sector here at NetApp. It is my great pleasure to welcome you to today's webcast, The Human Dimension of AI, a Public Health Perspective During a Pandemic, presented by NetApp. Today we'll discuss how the challenges of COVID-19 have highlighted the importance of innovative technology solutions, many that rely on data analytics and AI. Those same challenges have forced many of us to work remotely from home, limiting our human interaction to the confines of video conferencing. In order to design human-centered solutions, we need human connectivity, the one thing that we don't have during this pandemic. The more high-tech, the more human connections matter. And during this digital webcast, we'll be exploring how AI is being used for the public health during the pandemic. Before we get started, I'd like to go over a few housekeeping items. At the bottom of the platform, you'll find the Q&A tab, which allows you to ask a question. We'll be fielding those towards the end of the program, but feel free to submit questions at any point along the way. If you experience any technical difficulties, please contact us via the chat function. Now, my great pleasure, I'd like to pass it over to the floor to Kim Garriott, our Chief Innovation Officer of Healthcare here at NetApp, who will moderate the discussion today. Kim?
Yeah, thank you, Christopher. Hi, I'm really happy to be here with you this afternoon, and joining me is Dr. Kristin Honey, Executive Director of Innovation and Partnerships with the Department of Health and Human Services, Office of the Chief Technology Officer within the immediate office of the Secretary. Welcome, Kristin.
Thank you so much. I have to find the unmute button. Thanks so much for having me. Pleasure to be here.
You're welcome. Tell us a little bit about yourself.
Sure. So I'm a scientist by training. Did my PhD at Stanford University in a interdisciplinary biology program, so systems biology, mathy biology, and then came to DC in 2013 on a fellowship where scientists get put up on the Hill or in different agencies. I worked at Department of Energy for 2 years, and then went over to White House Office of Science and Technology Policy, where I led open data for President Obama. And open data, data interoperability, big data had really strong bipartisan support. So I was able to stay on in this administration and work for a year and a half under President Trump in the White House Office of Management Budget. So about 3 years total in the White House. And then 2 years ago, I moved to Health and Human Services, where it's really applying the data for a mission, data to solve problems. So I've been focused here for a couple of years on Lyme disease, now COVID-19, opioid challenges, mental health, a lot of different issues, but I'd say Lyme, tick-borne diseases, and COVID-19 are my big focus at the moment.
Great. Thanks so much for joining us today. And next we have joining us Esteban Rubens, and Esteban is my esteemed colleague at NetApp, and he is our healthcare AI principal. Welcome, Esteban.
Thank you, Kim. It's great to be here.
Yeah. Can you tell us just a little bit about yourself?
Yeah, I've been in healthcare IT for about 16 years. I started out in medical imaging and then drifted off to AI and machine learning. My background is in math, so it kind of makes sense. So I've been working for the last few years in building solutions, leveraging these techniques of artificial intelligence, and we'll get into this, to really improve the lives of providers and patients, and just thinking about the quadruple aim and other frameworks so that these things are not in a vacuum and they actually have some practical impact.
Looks like we lost Kim, so maybe we jump in.
I didn't know if it was me. Okay, all right. Well,
let's get started.
Let's get started.
No moderator, we can do anything. So the theme is the human dimensions of artificial intelligence and AI. Oh, now we can't do anything. Our fearless leader is back.
Oh no.
Yeah, thank you. I'm so sorry about that. I thought, of all days, internet connection. Somebody must be like, apologize for that, but we'll get right into it. we've all seen the promise of AI playing out in streamlining COVID clinical trials and other advanced clinical research, and the future is certainly bright as we look forward to applying AI in precision public health. But while the future is bright, today we find ourselves in a socially distanced world, and that distance impacts our ability to connect as human beings. And we know that the human dimension is critical in building not only great AI, but also in building trust in AI. So we're going to explore that today. And Kristin, we'll start with you. Let's just start beginning to talk about how do we care for that human dimension in AI, and kind of what does that mean to you?
Thanks, Kim. So how do we care for the human dimensions, and especially when it's high-tech topics? I think the first thing we have to do is listen. So get out into the world and think about what problem are we trying to solve. And then before building technology or jumping to a solution or thinking how any data, tech, AI could help address a problem, get out there and talk to the community that is dealing with the problem and listen with an open mind and ask people what their pain points are, or ask people what their priorities are and what would most help them. And really do that in an iterative way. So it's not like you get one answer and then go off to build all the technology, but you listen with an open mind, through that process, learn. And then I firmly believe in developing technology in a way, I call it co-creation. It's pulled from open government, so transparency in government. And how do you have good government? You co-create the government you want with the citizens we serve. And I think building technology done like that is the best way to incorporate the human dimensions and trust into AI. So you're co-creating through agile sprints, technologies or solutions with the users who are experiencing the challenges or problems. So not for the users, but with them, truly side by side, where their lived experience and expertise is sitting side by side with the developers or the subject matter experts from a more academic, technical side. And the solution is really involving those and is built with them rather than for. So my human dimensions is get out of the silos, get out of any academic bubbles, get out of our government offices, go out in the community, try to understand, and most importantly, when you ask the questions, what people want most or what they would like to have solved, listen. And then from that listening, truly work together, roll up the sleeves, and co-create the solutions, because there's huge insight and wisdom from different perspectives. And the only way to capture that, I think, is working side by side as equals, no matter what people have in terms of fancy degrees or not, or lived experience or not. There's so many different types of knowledge and experience out there.
Yeah, that's really great. And Esteban, I think you have an opinion on this as well.
Yes, yeah, thank you. So really what we think about is we want to make this inclusive, right? We want to focus on listening to diverse populations, especially in healthcare. We know models are brittle, so it's very important to sort of have data that represents all sorts of different populations, and we want to make sure that whatever we come up with is broadly useful. We don't want to live in a bubble. We want to kind of help solve real problems. There's a bit of an issue with technology becoming a solution in search of problems, and we don't want to contribute to that. We want to bridge the gap between the people who need the solutions, the people who have solutions to offer, and living the real world, the world that has legislation and the world that has constraints, budgets. So it's a bit of almost being ambassadors. I think a lot of us want to bring all these things together so that we come up with usable solutions, as opposed to kind of pie in the sky, idealized things that will never really get implemented.
I think that's so true. And you mentioned, brittleness of data. right? And I think that we understand that we are challenged oftentimes with data diversity and being able to rely on data integrity of the samples that we get to be able to inform or feed our AI models. So as we look towards that and around AI prediction accuracy, what are some of the challenges that that have been brought to light during the pandemic, and what are we seeing in data today, and how do we look to improve those conditions or improve the brittleness of data so that it's it's not quite so fragile and it has a stronger level of diversity and integrity?
Yeah, thanks, Kim. So the first thing I'll say is data quality, whether it's AI or models, just algorithms and models, not true artificial intelligence or machine learning. Data quality is paramount. If you don't have good data, all the fancy technology and models will just frankly be bad. It will get magnified and worse at every layer of analysis. So the further upstream we can go and make sure we have quality, meaning timely in reportingness, completeness, hopefully transparency, so people can see the source and that it has not been changed or where it's been changed, why it might have been changed. All those levels will make good data as far upstream as we can from as many sources as we can. And that, of course, leads to the paramount how important it is to have data governance and data standards. So you can have lots of different types of inputs, then these types of data can talk to one another. So I would say before even thinking of the AI front, the data quality going upstream and then trying to diversify where that comes from. And then that, of course, takes you down into the ecosystem of data governance for data standards and interoperability. And then within data governance, one thing that we are doing in government right now, and I think is paramount and will be more and more important as AI gets more sophisticated, is infusing data ethics into data governance and data use at every step of the process. So that's sort of my big answer is data quality. And the data quality involves data governance with ethics and people infused every step of the process. And when I say people infused every step of the process, that could be things like patients or people who help generate the data. So the data would not exist without them. Creative governance models that could give them agency and some way to collectively self-govern how their data is used. There are all these different models out there for how we govern data. And I think the AI issue is ultimately a data quality and data trust issue.
Yeah, and I think something really interesting we've seen during the pandemic is the emergence of this collaboration at a global scale. It's been really interesting to see some old preconceptions fall by the wayside because we need results, right? So now we're focused more on what we should be doing as opposed to, let's not do this because somebody may object and very interestingly for me, even techniques from artificial intelligence that really feed into this, like federated learning, right? It's a perfect time for this where, you don't even need to share the actual data. You can train models locally and then kind of merge all the trained models so that everybody benefits. So it's really interesting that even though it's a horrible situation that's still ongoing, it's triggered some, as everybody says, it's a catalyst. This pandemic has been a catalyst for so many things. And one positive thing has been this spirit of global collaboration.
That's a great point, Esteban. I think of it as problem solving with data and problem solving together. And there's no bigger problem in the globe right now than COVID-19. And it really is getting people to work in unique ways, break down silos, take whatever resources, data, skills, technologies can help answer this problem, and we're doing it together.
Absolutely, and that bell can't be unrung, fortunately, right? Now that we know what's possible, just really not likely that we would go back to the silos, even though there might be some pressure. It's like, no, we know that it's not even perfect, but it's better.
Yeah, great. Those are some great observations. And we started to talk about this a little bit and talking about involving citizens in the process, right? So what are some other methods to be able to improve the data diversity that we have? And today we hear, whether it's about COVID or it's around other things, that the data diversity isn't strong, right? We know that there are underserved populations, and that because of that, we're not capturing data from as many different sample pools, if you will, as we can. So what are some other ways that we can start to think about improving data diversity? Esteban, you want to take that one?
Yeah, so drawing from my experience in imaging, obviously you have probably more than I, but at the same time, if you think about things like point of care ultrasound, new technologies that bring the ability to obtain data to the field in ways that weren't possible before. Interestingly, even if you think about a company like Butterfly, where you have this all-in-one transducer that's connected to a smart device that's really portable, and you can have AI algorithms helping a layperson acquire good images. So that's just one example of how miniaturization, automation allow us to deploy technology to places where it wasn't available before, maybe approaching underserved populations that are very rural, very remote, maybe have never been served with imaging or other forms of healthcare. And that data can certainly be part of the global discussion now, whereas before it just wasn't even acquired. So I think the acquisition of data from populations that weren't part of the discussion is a really good technology-driven outcome now.
Yeah, and just adding on that, to diversify data, one thing that I've done for several projects is to think about expanding the solution space. So how can we engage new solvers or new disciplines to look at this challenge? And sometimes there's not trust in government. And so sometimes people will not share data or information if they don't trust the source it's going to. So we often will work with external collaborators or third-party neutral organizations and expand the solution space. So it's not just the data we have or that people are willing to share with us, but that we're augmenting it with other perspectives. And there's some, for example, with Lyme disease, which is a complex disease where the patient experience, for some who do not return to full wellness after treatment, does not match the peer-reviewed literature that much of it says Lyme disease is a bacterial infection and relatively simple to cure with a few weeks of antibiotics. But patients remain sick. So there's a disconnect between two worlds, the lived patient experience of some, and then this peer-reviewed research, and how do you bridge those worlds? So in expanding the solution space, patients actually created their own registry. And I think close to 15,000 people have already submitted all their information, their medical health records, in an effort to see, are there commonalities, are there patterns? If we all share our information, that we can, figure out what works, what doesn't, what's causing us to stay ill. And so I think that idea of crowdsourcing and getting information from people who may be coming at it from a different perspective is really powerful. And we're just starting now to be able to analyze and harness and look at that data. So I think of, in data diversity, how can we expand the solution space? How can we get creative to bring in new sources of data? And most often those who are creative to get outside sources are the ones facing the problem. And they have a real world challenge that they need an answer to. So they find ways around it. So that's my big thing, is always trying to expand the solution space, engage new solvers. And often it means letting go of the challenge myself. You lose control, but with that, with new perspectives, you end up coming, I think, to, sometimes it takes longer, but ultimately coming to more robust answers that will look at the whole elephant or all the aspects of the wicked problem, not just like one sliver that we might have had before.
Yeah, I think that's great, Kristin. And it's also, I think, as technology evolves and as the technology in our pockets evolve, I think we can also tap into socio-demographic behaviors and wearable devices or the Internet of Medical Things, right? So that we can start getting feedback and intelligence without citizens having to do something extra to share that, right? And I think the promise of looking at environmental data or, again, socio data, different things like this will give us insights that we've never, had the advantage of having before. And, as we look at things like the distribution of a vaccine or looking to see where hotspots are, not even related to COVID, right? We've had issues of wanting to understand public health environments by geography or by area. And I think that as we look towards leveraging AI, it will be able to help us predict where certain health issues arise, where we need to mobilize public health caregivers to most adequately take care of our populations. And as we look to that, what other ways are, Esteban, and do you see us being able to use AI to assist in the intervention of public health?
There's some fascinating work being done with data fusion, where we have worked with healthcare organizations that bring together EHR data, imaging data, claims data, social determinants of health, with the idea of early intervention. So you want to catch people before they develop disease instead of reacting to symptoms. So there's already things being done in real life in clinical settings for early intervention of cardiovascular disease, of diabetes, where certain people are flagged to care teams so that these much simpler and certainly cheaper overall interventions can prevent someone from developing a disease, which is certainly much better for the person because they don't become a patient, and it's overall cheaper for the health system. And so those things are quite interesting because they are they're available today. It requires, just back to the question we were talking about before, of data diversity and bringing different people together for collaboration, especially in a health system as fragmented as ours. It requires collaboration between payers, providers, researchers, even patients. You have people using natural language processing to do sentiment analysis. They mine some social media data to see what people are saying about themselves. So those are some really, really interesting things that are already happening that are not futures. They're not things that we wish we could do. We can, and they're actually being done successfully.
Yeah, Kristin, anything to add to that?
Yeah, agree with everything Esteban said. And one I think I'll add in terms of the sociodemographics and the feedback loop you were talking about, Kim, is that I think technology today is helping to make a lot of invisible health conditions visible, in the sense that qualitative issues like insomnia or not feeling great, or how do you put these qualitative symptoms that can come and go, and this happens with Lyme disease, it happens with it's now happening with the COVID long haulers, many different, often invisible diseases where you can look fine and the symptoms wax and wane. So if you're not in the doctor's office at that moment when your heartbeat, tachycardia goes up to 180, beats per minute, just sitting there resting, or your temperature doesn't spike at that moment, it's really hard to measure. But now with wearables and people have their heartbeat recorded, they can see their sleep quality. I feel like we have this wave of information coming, can be very personalized, but it also will be an era where what had been not very well understood, diseases or syndromes, whether or not we know what's causing them, we can at least validate the patient experience and say, you know what, you really are sick. You really are not sleeping well. You really, your energy and your activity fundamentally shifted from before and then after event. And those kind of things, I think, will be really empowering to the patient, because it will give voice and it will give data to something people know on their own, but we haven't yet really been able to translate that into personalized and precision medicine to the individual.
Yeah, that's so great. But don't you think there's a huge disconnect between what we have technology-wise and the EHR and this deluge of data? Because there are no good ways of getting those, ECG traces or, any number of other things. And I've actually been in presentations where cardiologists were saying, patients are emailing me PDFs off of their Apple Watch, and I can't do anything because it's not in the medical record. I mean, that is something that, in terms of interoperability and just general sort of forward thinking, the ISVs, the companies that make the EHR systems, the health record systems, they're going to have to deal with it because it's already here. It's not that it may happen. So that's a tall order for them, but they need to deliver.
Yep, absolutely. Kristin, do you have anything you wanted to add to that? I saw you nodding your head. Just want to make sure.
+1. I just +1. Completely agree with Esteban, and I think it's going to take a coordinated approach with all sectors. At least in our, U.S. federated, very fragmented system, where the role of government really, interoperability elements become so important beyond EHRs, but interoperability for all these different levels of data. And then industry working in tandem together. And then as the data standards and the ecosystem matures, we're doing that with all sectors kind of working together.
I think we may have some challenges with the connection that Kim has. So when we maybe talk about how do we take care of the human dimension, right? There's a lot of angst about negative perception of AI, just even if you think about, the Terminators are going to come and take us all. On the other hand, there's so much promise. Hey, Kim, sorry, I was getting into the next topic here. So what do you think about, Kristin? Like, how do we help with that, given that there is so much good that can come out of it and some of these negative perceptions are misplaced?
Yeah, I think you're right when you come at it at an abstract way. The combination of, AI Terminators, Big Brother, big tech companies, and it's just all these fears in one where, AI, people have different definitions for it. What are we even talking about? So I kind of go back to the problem solving. And if you take a concrete problem, like imagine someone has chest x-rays and their radiologist is going to read this, and you let them know that AI can do it just as accurately or more accurately, which would free up more time for them to be with their doctor. And some of the data is being interpreted, and then you could focus the human effort onto what to do with that interpretation or to validate it and then move forward. I think will change our dynamic, not just with doctors, but with professionals and experts, where you can free up human bandwidth for the creativity or the problem solving on that human to human level. And the technology is a tool so that the human brains don't have to put that energy and time in to do what machines can do quickly. So my experience is talking about it at a 30,000 foot level does not convince anyone to trust any tool, does not convince anyone to trust government. It just that the preconceived notions are too strong. But if you have a concrete problem and you've applied AI, another example would be matching patients with cancer clinical trials or with COVID clinical trials to facilitate that matching. So people, when they're in a unique, scary health situation, will get optimally matched to the best research and cutting edge opportunities for treating that condition. AI can do that much better than people in many ways. And so if you can let people know how AI is facilitating a situation and helping us come to solutions faster so that humans can be freed up to do the creative, problem solving together, listening to the patient for their unique risk tolerances, their preferences of how they might want to proceed, and then integrating that, then AI just becomes a tool and one of many tools in a toolbox and not some threatening thing that will take over our lives and displace us of jobs.
Well, and I think that's such a good point, Kristin. And if we look at a really practical application, I think if we use AI in a way that's very visible to our patients, that also helps to engender that trust, right? And I think about a time where it was very difficult for me to get an appointment for my mom with an endocrinologist. And when we finally did, I asked the doctor, I'm like, so why did it take 5 months to get an appointment with you, a new patient appointment with you? And she said it's because so much of their population that she sees is just simply bringing a glucometer in and having them read their reports findings for the past 30 days. When if we would leverage, IOMT, or the Internet of Medical Things, to be able to take those readings from the smart device, from their home, and then allow those findings to be triaged by AI, and then surface those patients that truly need to be seen in the office versus those patients that can stay at home, expose themselves to different germs. It does what you were talking about. It frees up bandwidth, and it also offers a more positive experience for our patients. And if they start seeing AI in that way, and they can feel it in their lives making a positive impact, I think those are the greatest opportunities we have to bridging the gap and bridging and building that human dimension in.
And also demystifying some of this stuff. I think words matter. I really worry about that and think about it a lot. And even the word artificial, right? That doesn't really help. And it doesn't help that we don't talk about the reality, which is it's all fairly basic math. You're talking about neural networks, and there's a lot of linear algebra. There's some differential equations. I mean, there's nothing particularly mysterious. It's certainly, and for all the concerns about, it's a black box, I don't know how it arrived at its conclusion. Well, our brains are a black box, right? We don't understand how our brains work anyway. So I think there's an interesting movement in which people don't even want to call it artificial intelligence, right? They call it augmented intelligence. It's a tool. It's a boring tool. It's something that should be in the background. It just helps in different ways. It's very narrow use cases. We're nowhere near AGI or, general artificial intelligence. So I think it's incumbent upon all of us who are participating in this discussion to try to clarify that an industry is not doing itself any favor, certainly by kind of pumping up that mystery, right? Instead of, it's just another tool. It's based in math. And even providers, I've had a lot of conversations with physicians, and they also don't know what's going on. It's like, is this going to replace me? And well, they're supposed to be scientists, right? So that's kind of shocking when that comes from their side as well.
That's an excellent point. And yeah, in terms of not pumping up AI and building trust, I think another element of that is being honest and calling a spade when it's not working. So I'm going to give you an example, a real world example from about a year ago. Here at HHS, we were doing a technology sprint for a lightweight process, a 3-month technology sprint for companies and industry to build digital tools from our government open data. And we provided, touch points, access to subject matter experts, but industry built the tools. So we had, I think, 6 tools that were for artificial intelligence and improving cancer clinical trial matching with patients and experimental therapies matching. And then 4 digital tools, I think, for Lyme and tick-borne diseases. And one of the tools was pretty awesome. It was by a middle school innovator who developed an app, a tick tracker app, and you could basically learn about ticks, like where there's dangers, or like what ticks are in your area, and then citizen science report the ticks that you find. So it really was crowdsourcing where ticks are, and then you can dive in to see what these ticks do. They carry human diseases, all that fun stuff. So after our tech sprint, because we had this middle school innovator doing a technology sprint with Oracle, Microsoft, Flatiron, these other huge companies. Out of that, she was approached and said, we could marry up some of our AI, and imagine being able to take a picture of your tick, and then the app will tell you what it is. And she's like, great. So her and her mom and family went, and they got pitched on how some of the big companies could help them with artificial intelligence to make their app better. And in the demo, they showed a picture of a cow. I think it was a white and gray cow. And basically the AI said it was a goat. And so the middle schooler was like, Mom, I think that's a goat. And it didn't go well. They did not embed AI in. But everyone in the meeting kept trying, or at least from the way it was relayed to me, kept trying to pretend that wasn't a problem. And artificial intelligence is not immutable. We get errors, and then you take that as feedback and you course correct and you make it better. But if you had outputs like that that are wrong, I think in order to build trust and to move and encourage adoption, the first thing you have to do is say, that's wrong. We have work to do. Let's revisit this in a little while. So call a spade and recognize AI is not perfect. Far from it right now.
Yeah, openness in general, right?
Yeah. Well, this time we're going to transition to our Q&A portion of the program. And I'd like to remind everyone that you can submit your questions that you have for us using the questions button located on your screen. And Esteban, I think we'll start with you. We have a question from James, and it's a good one. It's around how we will deal with the security around public health information, patient health information, and how do you prevent, nefarious acts with that?
Yeah. So as usual, it's going to be a multi-layered approach, right? You need security at the edge. You need security in flight, so encryption. You need data provenance as part of a governance policy. You need to be able to there are several technologies that are being used for this, like blockchain, for instance, basic hashing. So there are ways in which you can tag data when you acquire it and then compare that tag later on to ensure that it hasn't been tampered with. Certainly in terms of scamming the system, that's interesting because that is a weakness of some neural networks where there's been some fascinating work by researchers where they've injected what looks like random noise into a picture. There are some crazy examples where it's a dog and then they inject some random noise that makes for us, it makes no difference, but the neural network then thinks it's a gorilla or something like that, right? So it's a big difference. So again, it all goes back to policies, right? You need strong data governance. You need to ensure the provenance of data, and you need, it is possible, right? It adds layers, but they're very, very important layers. And then ultimately, people should control their own data. So there's a lot, even I think there are government efforts about that where you can decide what to share with whom. And that also will be important because sometimes people may not be comfortable sharing any data. Some people may be more interested in contributing to that. So it's really, there is no single answer. It's going to be multifaceted.
Kristin, I know this is a top concern in the work efforts that you're doing and that you've done in the past. Anything else to colorize on that?
I would just +1 on the transparency. It is so critical that we work as much as we can in the open, how data is being interpreted, with our HHS COVID response, some of the analysis data sharing is pushed to a new website, HHS Protect Public. And then part of my work has been really pushing the data underlying that, open data underlying that to healthdata.gov. And that's just a small little element on the data front, but I think we need to be equally transparent on the assumptions, the algorithms, the processing of the analysis. So I think that's always an ongoing thing. You're transparent and learn more, because when you do that, people can flag things you're missing and keep moving forward in this iterative process that we talked about before.
And we know that healthcare data is more valuable to bad actors than non-healthcare data, right? In the sort of black market, whatever you want to call it, it's the price attached to healthcare records is way, you can buy credit cards for pennies, right? That's not interesting anymore. But health data, and there's even been, some discussion about state actors going after the healthcare data of the military personnel, targeting clinics near bases. So we know this is happening. So clearly being aware is number one. And then having some kind of, whether you want to call it regulation or, something that binds people who consume this data or have access to it to protect it, because it's not just the acquisition or the transmission, it's that data can end up in several different places, and it can be targeted in any number of those different places. So it has to be protected, by the recipient as well while they use it, and then potentially destroyed properly, right?
Now, Esteban, I'll ask you another question. We talked about being able to use, leverage surveillance situation. You're very focused on always applying and tying back to accomplishing the quadruple aim. So as we look at how AI can aid in early intervention, how do you think that will help support the quadruple aim and help us satisfy?
Yeah. I'm missing some of the audio, so I'll answer the quadruple aim question in different ways, right? Different aspects of the technology will help with different, of the 4 aims of the quadruple aim. One that I like to focus on is improving the quality of life of providers, right? We know that there's an epidemic of burnout, not to mention lately, this pandemic has added just enormous strain to everybody, all caregivers, everybody working in healthcare. So as Kristin was saying before, this idea of removing menial tasks, or, you, Kim, were saying that too, we can free time up for people to do things that they're better at. And also, the menial tasks are not trivial, right? Because they interfere with people's lives, when they go home and they have to do charting, even after they have some family time. And that's ultimately demoralizing, right? Because it's a Sisyphean task. You will never be done because there's always too much to do. So if you will, in terms of low-hanging fruit, that would be wonderful, right? Because we haven't really focused enough on burnout. It's a big part of the conversation in healthcare, but outside of healthcare, it's not as well known. And many times patients are not aware of that. They're not aware of the horrendous strain that their doctor, their nurse, their provider is under. So there is a very clear opportunity to remove some of those menial tasks and to improve the quality of life for caregivers, and technology can certainly do that.
Absolutely.
Yeah, and
absolutely.
I think technology, emerging technologies can also maybe help serve as an early warning sign, where when you're going, and there's a pandemic response, and we all have to give it our all. It's a whole of America response. Burnout is huge in many disciplines, but sometimes the technologies can be that data reminder to slow down when it may be hard on your own to listen to the signs of your body. And so that preventative way, not just in terms of improving the quality of life and avoiding menial tasks, but also the early warning signs, and then helping people, especially folks like myself who have a hard time asking for help or a hard time saying no. Say, you know what, for the long haul, for going to be in this marathon, I'm going to dial it back a bit because you have data that shows you're putting yourself at risk. I think that the technology can help us that way. The other way it occurred to me, Esteban, when you're talking about the quality of life of providers, is it gets back to the human dimensions of what are we solving and what do people want? And the quality of life for everyone, we want slightly different things. Preferences are different. So I think it goes back to the importance of asking people, what are we solving for? What do they want? Understanding that, and then harnessing, the full power of technology and AI to drive towards those solutions. But the quality of life of providers will not be the same for everyone. It will be a heterogeneous mix. And so I think that could be an opportunity to customize and tailor what the outcomes will look like. Because what makes one doctor stress could be a relief to another one. And it's that important sorting and matching that new technologies can help us do more.
No, I love that. And you're right. And that's that we can get with AI so that every experience is tailored, right, to that individual. So thank you. We've reached the end of our time, but I want to give you a big thank you, Kristin, for joining us in Esteban, and thank you again for such a great conversation. Remind us that this digital event has been recorded and it will be available on demand on the event website. You'll also be receiving the recording via email, and we encourage you to pass it along to your colleagues. We thank you for joining us today, and we hope you have a fantastic rest of your day. See you next time and stay healthy. Thank you.
Thank you.
Thanks. Bye-bye.
Bye.